Now let us begin our part 2, and in this part 2 we'll see amyloidosis. So what is amyloidosis? Actually it's an abnormal misfolding of protein and that is getting accumulated in the extracellular space. So actually the structure is like beta pleated linear sheets and they are insoluble fibrils. Actually they lead to the cellular damage and finally apoptosis. And we can see this amyloids by Congo red stain, and we see it under polarized light, and this apple green bifringence. You can see this is a apple green bifringence and this is the Congo red stain. Even we can use HND stain. Now let us see different types of amyloidosis. Actually it is divided into systemic amyloidosis and localized amyloidosis and hereditary amyloidosis. So first one is systemic. Systemic you can understand according to the name, it's systemic, like in different organ systems. So in systemic also it is again divided into primary, secondary and dialysis related. So primary amyloidosis will be having AL protein, and that AL protein is from light chains. So AL, LL, that is L for light chains, and this is seen mainly in plasma cell dyskaryosis, example multiple myeloma. And next coming to secondary amyloidosis, it is having serum amyloid A, that is SAA, or also you can see AA. This is secondary amyloidosis seen mainly in chronic inflammatory conditions like rheumatoid arthritis, IBD, familial Mediterranean fever, infections. Dialysis related amyloidosis will be having beta 2 microglobulin, and this is seen in patients with ESRD and with long term dialysis patients. So, the most common clinical manifestations of systemic amyloidosis is there will be having restrictive cardiomyopathy, macroglossia of GI system, hepatomegaly, or in renal nephrotic syndrome. In hematological, they'll be having easy bruising, splenomegaly. In neurological, they'll be having neuropathy. In musculoskeletal, they'll be having carpal tunnel syndrome. Now coming to localized amyloidosis, Alzheimer's, there's a memory problem. There's an accumulation of beta amyloid protein which is cleaved from APP, which is a precursor. Next coming to type 2 diabetes, there's islet where amyloid polypeptide is getting accumulated. It is because of deposition of amylin in pancreatic islets. Next coming to medullary thyroid cancer, where there's deposition of calcitonin. In isolated atrial amyloidosis, there's deposition of ANP, which is common in aging, and because of this there's increased risk of atrial fibrillation, that is atria is undergoing fibrillation process because of ANP. Hence the name isolated atrial amyloidosis. Only in atria there's ANP. Next coming to systemic senile. Senile means age related. Very old people have this kind, where there's normal type and wild type. Wild type is normal. TTR is a transthyretin. Very important that this transthyretin in senile is non-mutated. It's non-mutated and it is seen mainly in ventricles, and there is cardiac dysfunction, especially AL amyloidosis. Now coming to hereditary, it is divided into familial amyloid cardiomyopathy and familial amyloid polyneuropathies. So amyloid cardiomyopathy, here there's mutated. So here non-mutated, here mutated transthyretin, where it is affecting ventricular endomyocardium. There's restrictive myopathy and arrhythmias. In familial amyloid polyneuropathy, there's mutated transthyretin, so that is leading to mutation. Now let's continue with inflammation. So actually what is inflammation? There are different signs of inflammation. The main thing is we want to eliminate the cell injury causes, so we were getting ready to do inflammation. Here mainly we remove the necrotic cells and also we initiate the tissue repair from the inflammation itself, and this is divided into acute and chronic inflammation. In acute inflammation mainly the neutrophils come out of the cell, and in chronic inflammation the lymphocytes come off the cell. And this inflammation process is harmful if there is harmful especially to the host if it is excessive, like in septic shock, or if it is prolonged, like in TB infection, like in chronic inflammation, or it is inappropriate like autoimmune, like diseases SLE, scleroderma, Sjögren syndrome. In all those it is autoimmune. So what are the main signs of inflammation? Rubor and calor means, rubor means redness, calor means warm, and this rubor and calor is because of vasodilators. What are the major vasodilators? You have histamine, prostaglandin E2, bradykinin. All these are vasodilators. Of course nitric oxide, they increase the blood flow. So there's more warmth and redness in the site of inflammation. Next, tumor. Tumor is nothing but swelling. How you get swelling? This is also because of vasodilation, that is, we have vascular permeability. But this swelling is mainly because of histamine and serotonin, and also endothelial contraction by leukotrienes. So leukotrienes are actually coming from, arachidonic acid. If you know that process, arachidonic acid actually come from phospholipid, which is coming from phospholipase A2, and that will form cyclooxygenase and lipoxygenase. Cyclooxygenase will form PgI2D2E2, whereas lipoxygenase will form leukotrienes. Leukotrienes is a powerful vasoconstrictor, whereas histamine, prostaglandin, bradykinin, all these are vasodilators. Okay. Now coming to dolar. Dolar means pain, and pain is because of sensory nerve endings. And this pain, very important, pain is mediated only by two substances. One is bradykinin and another is a PGE2. Even histamine. Histamine, important thing is it causes pain plus swelling. Okay, swelling by histamine and pain also by histamine. Whereas PGE2, pain plus fever. Okay, and bradykinin, pain plus vasodilation, right? That is rubor or calor. Now coming to another one, that is functiolacia. Functiolacia means loss of function. That is, inflammation impairs function. With inflammation there's no function, like unable to make fist due to hand cellulitis. So someone is having cellulitis, they are unable to make fist because that is because of inflammation they are losing some function. Okay, very important, functiolacia. Now let us see acute phase reaction. So in acute phase reaction, mainly you will have fever. Why fever? Because of pyrogens. And pyrogens, example LPS of bacterial membrane. Actually they are induced by macrophages. So they release mainly are interleukin 1 and TNF. So because of this there's more COX activity, and that will activate the hypothalamus and increase the set point, right? So increase PGU2, PGU2 pain and fever, right? Next, coming to leukocytosis, in the name itself you can see cytosis, increase number of cells, increase number of WBC cells. So because of that, there's injury inciting agent like bacteria, they increase more neutrophils. Like whenever there's bacteria, it is, increasing more neutrophils. Increase plasma acute phase reactants like serum concentration significantly change in response to acute and chronic inflammation. Mainly it is produced by liver. So acute phase reactants are produced by liver, notably by IL-6. So IL-6 is important for acute phase reactants. So let us see some acute phase reactants. You have C-reactive protein, which is opsonin, which fixed complement facilitate phagocytosis. So opsonin for phagocytosis, and this can be measured clinically to know whether the inflammation is now at present going or not. Next, ferritin. Ferritin bind and sequester iron to inhibit microbial iron scavenging. You know that, right? Iron, if it is in normally in our body, it is in Fe+2 state, and if it is left like that in the blood, bacteria may eat that. So we prevent it by ferritin, and it binds with iron, so prevent the bacteria from eating it. Now coming to fibrinogen, it's a coagulation factor. It helps in endothelial repair and also correlates with ESR. What is ESR? We'll see next. Okay. Next, haptoglobin. Actually, it binds extracellular hemoglobin and protect from oxidative stress. Next, coming to hepcidin. Hepcidin decrease iron absorption and decrease iron release. So, especially in anemia. In anemia of chronic disease, hepcidin is present because it decreases iron absorption by degrading ferroportion and decrease iron release from macrophages. Procalcitin, increase in bacterial infection but normal in viral infection. Next, serum amyloid A, it is leading to prolonged elevation, so it will lead to amyloidosis. Next, coming to negative downregulated. The phase reactants which are downregulated are albumin because reduction conserves amino acid for positive reactants. And transferrin is internalized by macrophage to sequester iron. Whereas transthyretin is also called prealbumin. It reduction conserves amino acids for positive reactants. Let's continue with ESR. So what is erythrocyte sedimentation ratio? In the name itself you can see erythrocyte sedimentation. Sedimentation is like when the heavy particles get down, like if you take sand and water, the heavy sand will get down of that water, so that is sedimentation. So here the heavy RBCs, actually RBCs are separated by means of negative charges. Here you can see clearly this negative charge. So what happens is, especially in the case of inflammation, the negative charges will drop so that RBC can't get separate. They'll get aggregated and they'll become more weight, more denser. So they'll fast faller, that is called as ESR. So that will rise the ESR. So we can also test ESR along with CRP, which is most specific marker of inflammation. So increased ESR is seen in anemia. In anemia, there's decreased negative charge. There's more RBC aggregation. In infection, also there's more RBC aggregation and more ESR. In inflammation, in cancer, in renal disease, pregnancy, all this. Whereas ESR is decreased in sickle cell anemia, because in sickle cell anemia the negative charges are more because of altered shape. They are separated. They are not getting it. Getting down of the tube. In polycythemia also there's more RBC but not waiter. In HF, that is in heart failure, microcytosis, hypofibrinogenemia, all these conditions. Now coming to our main topic, acute inflammation. This diagram shows here acute inflammation, that is the neutrophils come out. It's actually early response to any kind of injury or infection, and this is always associated with edema. The cells in the center and also the edema will be coming out. It is a rapid onset, but it will be only for shorter duration, and the innate immunity also comes under acute inflammation. So the stimulus for acute inflammation will be like different infection, traumas, necrosis, even some foreign bodies can also cause acute inflammation. So this is mediated by some mediators called toll-like receptors, arachidonic acid metabolites, neutrophils, eosinophils, antibodies, mast cells. Very important is excuse me, mast cells mainly secrete histamine early, and in delayed response it will form interleukins, and basophils complements. We have classic pathway, alternative pathway, and mannose lecithin pathway. Hagement factor, it's in the liver. It will come to the site of injury. So all these are different mediators. And there's an inflammasome. What is this? It is a cytoplasmic protein complex which especially recognize the dead cells, microbial products, crystals, and that will lead to activation of interleukin 1 and inflammatory response. So when you see some antigen like substance like some bacteria, dead cells, then this inflammasome will activate and it will try to clear it. Now coming to different components of acute inflammation. The vascular component in acute inflammation, there will be vasodilation, increase endothelial permeability, and in cellular there will be extravasation of leukocytes. Mainly neutrophils will be coming out from postcapillary venules, and that will lead to accumulation of leukocytes in the site of injury, and that will lead to leukocyte activation. So mainly to bring the cells and proteins to the site of injury or infection is the main function of acute inflammation. Leukocyte extravasation of 4 steps. First one is margination. All the neutrophil will come to the margin of the blood vessel. Next one, rolling. There are 2 speed breakers, P-selectin and E-selectin. Next is adhesion. That is a gum-like structure with integrin, ICAM, and you also have IL-1, TNF. And transmigration is because of C5a and LTB4 leukotriene, which will attract the neutrophils towards outside. And finally, migration, chemoattraction. So the outcomes, the final product after this acute inflammation is either we can stop this process by resolution and healing by activating IL-10 and TGF-beta, or else we can continue the acute inflammation by IL-8, or else we can just form an abscess, or we can go to chronic inflammation by calling our helper T cells, or just we can make a scar out of it. So the macrophages predominate after 2 to 3 days of acute inflammation. So immediately after inflammation, you'll get neutrophils. After 24 hours, these neutrophils will again go back after completing their work, and next the macrophages will come for 2 to 3 days, and they will start secreting mainly cytokines. Macrophages will secrete cytokines. Now coming to leukocyte extravasation, how this process occurs. The first one I said already, it's margination. So here you can see this is the blood vessel. They have come to all the margins. The leukocytes have come to margin. It is because of C-allele Levy-6 and also because of E-selectin. E-selectin is activated by TNF and IL-1. P-selectin is coming from Weber pellet bodies. Very important. Okay. Now coming to adhesion. Adhesion means tight binding. So second one You can see this is the addition, how they are getting p-selectin, e-selectin is seen in rolling process. Okay, now coming to addition thickening, it is because of the gum, TNF and IL-1. Okay, and ICAM, VCAM, integrins, everything help to bind. Next, coming to the third process, that is diapedesis or coming out transmigration. It is because of neutrophil attraction by C5a and our outside LTB4. Okay, so finally it will exit the blood vessel. You can see how it has come out. And finally migration, WBC travel through interstitium to the site of injury. So these are the four process, that is margination, rolling, adhesion, transmigration and chemotaxis. 5 process. Okay, so after acute inflammation, you will have chronic inflammation. The chronic inflammation is where, in the name itself, you can see it's chronic. It will last for a long time in persistent infections, traumas, or especially virus, fungus, and also in cancers. You will find this chronic inflammation. And here the key cells are lymphocytes. So lymphocytes, there are T cells and T lymphocytes and B lymphocytes. Actually, T lymphocytes, they form in the bone marrow and they'll go for education for the thymus. And in the thymus, they divide into either CD4 cells and CD8 cells. And CD4 cells are interdivided into two helper cells, Th1 and Th2 helper cells. Okay, and the stimuli for this are mainly infections, fungi, virus, and type 4 hypersensitivity, autoimmune diseases. The mediators are very important, macrophages. Of course, T cells are very important in chronic inflammation. So Th1 cells secrete IFN gamma for macrophage activation. Th2 cells secrete IL4 and IL13, also IL5 for alternative activation like repair and anti-inflammatory. So final outcome of chronic inflammation is scarring or either amyloidosis or neoplastic transformation, or chronic gastritis in Helicobacter infection may convert into gastric adenocarcinoma. Now coming to wound healing. So wound healing also becomes hand in hand. It begins hand in hand with the inflammation. Actually, wound healing. There are several tissue mediators for wound healing, like FGF for angiogenesis, TGF beta for angiogenesis and fibrosis, VEGF for angiogenesis, PDGF for platelets, macrophages, and also to stimulate the fibroblast growth for collagen synthesis, metalloproteinases for tissue remodeling, EGF for cell growth. So coming to inflammation, after up to 3 days after wound, you will be having platelets, neutrophils, macrophages. The clot will form, vessel permeability will increase, neutrophils will migrate to tissue, macrophages will come and clear it out. After 3 days after the wound, you'll get fibroblasts, myofibroblasts. Actually, this is forming granulation tissue. Fibroblasts, myofibroblasts, capillaries, keratinocyte, macrophages, right? Granulation tissue. Mainly it is having type 3 collagen, and this type 3 collagen, at last, if we want to form the scar, it should convert into type 1 collagen, okay? By the presence of zinc. You can see delayed wound healing in malnutrition patient, diabetic patient, in some vitamin C, copper deficiency patients. Okay. Finally, coming to remodeling, that is from 1 week to 6 or months after wound. Mainly, you'll have fibroblasts, that is type 3 converted to type 1 because of collagenase and zinc. Okay, so if you don't have collagenase and zinc, you can't convert type 3 to type 1, and sometimes if type 3 will be more, it will cause hypertrophic scar. Okay, zinc deficiency will also lead to delayed wound healing. Very important, zinc. Now coming to granulomatous inflammation. Already we said that it is because of T cell immune response. It will form a wall of stimulus. Persistent inflammation will lead to fibrosis and organ damage. You can see here the focus of epithelioid cells surrounded by lymphocytes, multinucleated giant cells. Actually, this granulomatous inflammation is of two types, caseating, non-caseating. If it is caseating, it has necrosis. If it has necrosis, it have no nucleus. Okay. Example is TB fungus. If it is non-caseating, it is having no necrosis, means the nuclei are present. It is seen in autoimmune diseases like sarcoidosis and Crohn's disease. We should see the mechanism now. First one is APC, antigen presenting cell, present the cell to antigen to CD4 T cells, and they secrete the IL-12 and it will give to CD4 T cells, and they will differentiate into helper 1 cell. Okay. So what is happening? Antigen presenting cell will present antigen especially by IL-12 to T cell, and T cell will form T helper 1 cell, and this helper 1 cell secrete IFN gamma, and that will lead to activation of macrophage. As the macrophage is activated, it will lead to increased cytokine, especially TNF, that will lead to formation of epithelioid macrophage and giant cell. So anti-TNF therapy is used to break the granuloma. Okay. So always test for latent TB before starting anti-TNF therapy. This is associated with hypercalcemia due to increase in 1-alpha hydroxylase in macrophage, and also result in increased vitamin D. So in this mechanism you will have more vitamin D, and also you will have more hydroxylase activity. So this is how granuloma form. First IL-12, so it will due to TH1, and this TH1 will form IFN gamma, and this macrophage will release TNF and finally form granuloma. Now let us see about scar formation. So scar formation is like seen mainly in repair system of wound healing, where type 3 collagen is converted to type 1 in the presence of collagenase and zinc. We know that. So sometimes if there's excess TGF beta, then that is associated with some aberrant, that is abnormal scarring, like you can see hypertrophic scar and keloid scar. So you can see this is the hypertrophic scar because there's more collagen 3, and you can see it's parallel in organization, and this scar is confined to borders of the original lesion. You can see only in the borders it's hypertrophic, and this recurrence is infrequent, and predisposition, actually it doesn't have any predisposition, suddenly it comes. Next, coming to keloid scar, it can see how much it is disorganized. It has type 1 and type 3 both collagens more. It is very much disorganized, and it extends beyond borders. You can see like claw like projections, especially seen on earlobes, face, upper extremities, and this is frequent in recurrence. It can recur frequently, and this will lead to increased incidence, especially in dark skin. In dark skin people you see more keloids. Now welcome to neoplasia. So neoplasia, neoplasia is actually what? In the name itself you can see neo means new, plasia means growth, new cell growth. So new cell growth, but it is uncontrolled, irreversible and monoclonal. You need to understand this term monoclonal very much. What is monoclonal? One parent is giving rise to many daughters. Actually, hyperplasia is polyclonal. That is one parent, two children. One parent, two children. That is normal. Polyclonal, that is a hyperplasia. But in neoplasia, you see monoclonal, one parent giving rise to many daughters. So this neoplasia can either be benign or malignant. Important feature of benign is it will be mobile. If you touch the benign one, it will be mobile. It will be well differentiated. Whereas if you see malignant one, it will be very huge mass. It will not mobile. It will not move. It will be sticky. It will be to the one place. Okay, and the neoplastic have two components, that is the neoplastic cells and the supporting cells. Okay, the supporting cells either can be blood and connective tissue. Now let us see this diagram and understand how the neoplasia is forming. So first, normally you'll have the normal cell. So normal cell will be having a basement membrane, you can see like this, epithelial cell, and a blood or lymphatic vessel inside like this. So this is a normal cell which is called apical polarity. See cervical example A. You can see here A in cervical cancer. Generally, this is a normal cell. You can see all the normal cells. Now we'll go to dysplasia. Dysplasia is what? It's a precancerous cells. You can see these cells. These are the precancerous cells. There's lot of loss of uniformity, that is pleomorphism. Okay, loss of uniformity in size and shape, and also loss of orientation. And there are also nuclear changes like nuclear to cytoplasmic ratio. I mean, nucleus size is more than cytoplasm. For example, if you take this as a cell, the nucleus will be this much, and the cytoplasm will be low. That is increase in nuclear to cytoplasm ratio. You can see here disorganized, dysplastic cell. You can see the nucleus is very big, and this is reversible. Very important. Dysplasia is reversible. Even metaplasia is reversible. But both of these can convert into neoplasia. Now the third cell which you see is Carcinoma in situ. In situ means in particular location. It's pre-invasive, like it's irreversible. Now it is irreversible severe dysplasia involving entire, you can see here, entire thickness of epithelium. But it does not penetrate the basement membrane. You can see it will not penetrate the basement membrane. This is the moderate and this is a severe dysplasia, and these both are irreversible. Finally, invasive carcinoma. Invasive means it has broken the basement membrane. Actually, there are ecadherins binding them. First, the ecadherins will be lost. Next, the laminin will be broken of basement membrane and it will come out, bind with fibronectin. Now, it can either go into lymph vessel or into blood. Mostly cancers will go to lymph. Some will go into blood like sarcomas, and some other exceptions are there. Okay. So you can see this is invasive. Next, coming to metastasis, the spread to distant organs via lymph or blood, mainly by lymph. Mostly cancer spread by lymph nodes. Now let us see nomenclature of tumors. Carcinomas, actually, as I said, if they're epithelial origin, otherwise sarcoma if they're mesenchymal origin. Okay. So benign tumors, well differentiated, well demarcated, low mitotic activity, no metastasis, no necrosis. But malignant tumors, poor differentiation, erratic growth, local invasion. Okay. So now let us see the the nomenclature. First one, the tumors which are arising from epithelium are adenoma and papilloma. These are benign. Okay. So oma, ending with oma are all benign. Of course, some exceptions are there. Malignant, the same one will be adenocarcinoma and papillary carcinoma. If coming to blood vessels, hemangioma, angiosarcoma. Okay. Blood cells, leukemia, lymphoma. Smooth muscle, leiomyosarcoma. Striated muscle, rhabdomyosarcoma. Connective tissue fibroma, fibrosarcoma. Osteoma, osteosarcoma. Lipoma, liposarcoma. So same. In melanocyte nevus, melanoma. So this is the nomenclature. Like oma mostly belong to benign. Carcinoma, noma mostly belong to malignant. Now, very important, tumor grade and stage. So actually we see the grading and staging of tumors. The grading is dependent on degree of cell differentiation and mitotic activity. So if it is low grade, it means it's well differentiation. You can say well differentiated, so low grade. That means this cancer can be somewhat treatable. Okay. Whereas high grade, you can see poorly differentiated, undifferentiated. Undifferentiated is also called anaplastic, poorly differentiated. So higher grade with higher aggressiveness and very low chance of survival. Okay. So coming to stage. Stages depend on invasion, spread. Okay. So they are mainly dependent by T and M staging. T is for tumor size and invasion. N is for lymph node and M is for distant metastasis. So staging is more prognostic than grading. Very important. Okay. High stage but low grade tumor is usually worse. Okay, high stage staging is more important, even though it's low grade, but it's high stage, right? So that tumor is very worst.